So it is going to be more about the trends and tendencies and history of the surgery. The very first surgery, if you ask people who are from the United States or people from the United Kingdom, they keep repeating that the first Chiari malformation surgery was by Dr. Gardner. Now, if you knew German, at that point you would discover that actually the first surgery was actually done by a Dutch guy, and the very first Chiari malformation decompression was actually from 20 years prior. These were kind of the heroic age of Chiari. You can imagine what were the outcomes back then. Number one, you were having people, no MRI, no CAT scan. You're having people with the extreme too little, too late clinical presentation. You were having medical disasters, guys with, where you're doing that for the first time. There were no books, no rules. So you can imagine the very first patients operated on, they were not successes. They were far from that. The modern surgical era started with Bernard Williams in the United Kingdom. Bernard Williams was late 70s, early 80s. Bernard Williams was a neurosurgeon who, out of a, he was doing a little bit of everything like everybody does. And one day, met this patient called Anne Conroy, who was a patient with syringomyelia. And this patient was very determined, very courageous, very brave, very feisty. And they made this doctor-patient team, which drove the very first Chiari organization, which is still present today, which is the Anne Conroy organization, or Anne Conroy Foundation. So all of a sudden, there was this impetus of the doctor stimulating the patient to, to raise awareness, the patient stimulating the doctor to raise more understanding, and that team kept going. And Dr. Bernard Williams was the first one tackling the problem of Chiari malformation with numbers and with the systematic effort. Very soon, one problem started, which was that one of the cerebrospinal fluid leakages. If you start doing a lot of Chiari surgeries, cerebrospinal fluid leakage is there to get you the first time you try. And the incidence of pseudomeningocele, the incidence of leakage outside of the dura after you open the dura and repair it, was so high that was unacceptable in his eyes. So he tried every trick that he had in the book with the tools that he had at the time, and reached the conclusion at the end of his career, the pseudomeningocele is such a problem that if we open the dura, we should leave it open. Now, the issue was not that blaspheme, because in many other pathologies, the dura was left open at the time, and is still kept open now. For example, many people still now, when they open it, when they deal with a tumor of the posterior fossa, they open the dura and they leave it open in order to prevent the swelling of the brain from the surgical manipulation to backfire. Right now, the more modern approach to brain tumors is that one of closing the dura with the duroplasty, but that's a different story. But back in the days, his final stand about leaving the dura open was not really that absurd, given the perspective, and given the fact that at that point, he was the guy with the largest experience of Chiari. So if he could not fix the cerebrospinal fluid leakage problem, at that point, you had to listen to the guy. That created a separation between the United Kingdom and the rest of the world. Bernard Williams was such a towering figure in the field of neurosurgery and Chiari that still now the majority of the British neurosurgeons leave the dura open in Chiari surgery in deference to Bernard Williams. Now, the problem became no longer a problem when new materials, new techniques were applied to the problem. So the golden age continued with Dr. Betzer for UCLA. Dr. Betzer was the first one taking the torch from Bernard Williams and saying, okay, so how do we make this better? So he defined the size of the bonework, which means how big should be the hole in the back of the skull. You remove the entire back of the skull, you remove a piece which is like 1 centimeter, 2 centimeters, how much? So he started by, obviously like everybody does when there is no rule book, by trial and error, finding what were the things which were working better. He also perfected the duroplasty technique with materials, with choice of the material to use, choice of the stitching, choice of the needles, choice of how to pass the needle in which direction, etc. So he changed the incidence of the pseudomeningocele down to the point that in the hand of experts, closing the dura became an acceptable problem. So, for example, to give you an idea, a national expert, an international expert right now, they have consistently between 3 and 8% of cerebrospinal fluid leakage rate. People who do not have expertise and they do something like a few Chiari per year, few I mean less than 10, they generally have, they're not pros, they're good neurosurgeons, for anything else, but they're not Chiari experts. Generally the incidence of cerebrospinal fluid leakage goes between 18 and 48% if you open the dura and do a duroplasty. So Dr. Besser was in the single digit back in the early 90s. He was also one of the first proponents, but the first one adopting on very large numbers, of the tonsillar shrinking. The tonsils, cerebellar tonsils, have no function whatsoever. They are like the appendix for the brain. If you shrink the tonsils are going to be pushing less against the the structures which are in the area. So it is like removing the appendix. If the appendix is making you sick, taking it out makes you better, and with no counter effect. If you remove the tonsil, if you cut the tonsil, if you burn the tonsils, that doesn't affect your neurological function. So it doesn't make you stupider or klutzier or whatever. So Dr. Besser was the first one adopting a systematic approach to the tonsillar shrinking. And so his complication rate became much lower. Dr. Murad, and to a point, me, because we were co-surgeons for most of our Chiari career, came up with advances on what Dr. Besser and Dr. Williams had built. The first one is that on the tailored surgical technique. So different size of decompression for different people. Making small changes to the surgical technique in function of the single anatomy of that single patient was giving better results. So we were paying attention to the anatomy from the MRI, in ultrasound anatomy, the anatomy we were seeing with our naked eyes, and we're just changing those building blocks that already Bernard Williams and Dr. Besser had put on the table. Then we also introduced the color Doppler ultrasound. Color Doppler ultrasound was important for decision making. So one of the major discussions at that point is, and still now, so you just cut the bone and you cut, the pressure loose over there, or you also have to open the dura. And some people just open the skull and they stop there no matter what. Other people, they go all the way no matter what. Other people, they say, all right, let's see how it goes. So I start doing one step and then I check with the ultrasound how the anatomy has shifted or changed. And one of the main parts here of the Chiari surgery was, all right, Chiari has an effect on cerebrospinal fluid flow. The tonsils are in a position that are stopping the cerebrospinal fluid flow in the same way that the tractor trailer jackknife would obstacle the traffic on the highway. So that said, is Chiari just a cerebrospinal fluid flow problem? No, because the tonsils also behave like a mass effect. Imagine that you have a tumor in the area over here that is compressing the brainstem. The brainstem is compressed, and the brainstem being compressed creates problems. So the double sword, the double pincher with which the Chiari attacks you is the Chiari creates an obstacle in the cerebrospinal fluid flow, hence all the problem with the pressure that you have when you cough, but also creates a lot of pressure on the spinal cord and the brainstem and on other structure like the foramen of Magendie, which cause and on the 11th cranial nerve, which cause symptoms of their own from the mass effect. So how do we see all these things during the surgery if you don't want to open the dura? At that point, we were using the ultrasound, and we were checking the ultrasound to measure flow. Now, the color Doppler ultrasound was introduced in the early 80s in cardiology to measure the blood moving in the vessels in the blood. But up to that point, and we were talking about 1995, 6 when I did it the first time, nobody actually was able to get flow out of the CSF. I had some physics background, I picked a good machine, I turned a couple of knobs, I was able to do it, and the rest is after that. We were also the first ones having a systematic approach to reduce surgeries. And trying to understand why a former surgery by us or by somebody else had not given the best result, not accepting it in the first place, and trying to do further, trying to get further and trying to get better results. So at that point, we started seeing different kind of categories. And then another of the big contributions of our group was the recognition of the comorbidities. This is an example of the interoperative ultrasound showing the dura, the tonsil, the form in the brainstem, a odontoid here, which is making the sandwich we were saying before. Here you see a Marie Antoinette cut of the upper part of the spinal cord with the syrinx inside and the dura here, cerebrospinal fluid here. And this is how that black fluid here that you do not know if it's moving or not, how you can measure it. That's important because let's assume, for example, that the skull is compressing all the way here. You decompress the skull, the dura expands, and there is space here. Many surgeons equate the presence of space, for example, let's go here. You see here there is practically no space between the cerebellum and the dura, okay? This is after we remove the skull, but let's assume, for example, that we have the skull here. We take the skull off, and the dura expands a little bit, and now there is black signal here. The black signal simply shows that there is subarachnoid space. Space does not mean flow. Even if the dura moves, even if the cerebellar tonsils moves, why it is not flow? All right, flow is when you have movement of things from point A to point B. Now let's assume for a second I'm going to make a fool out of myself. I go from here to there, all right? And I walk, and that is movement. So if I am one red blood cell, that's a blood cell moving. But imagine for a second that I'm a little bit, off, and I just do like this. I'm moving, but if you go see at the beginning, at the end of the speech, you're going to see there is no net flow. I have not moved from point A to point B. So a lot of patients who, when we were recording with the cerebrospinal fluid with the color Doppler, we're seeing that not all the time we were going to see that cerebrospinal fluid space, we were actually having flow, measurable flow inside. So it's a dangerous assumption by the surgeon using an ultrasound, which is not color Doppler, but the standard one, to see CSF space below the dura and assuming, and you know that assume is a funny word in English, assuming that that is the equivalent of flow. Flow is flow when you measure it, and the color Doppler is the only way to do it. Intraoperatively, outside of the operating room, you use the cine MRI. Towards the mid of our experience, we defined surgical goals. They're still, accepted now. One is to restore the balance between the small box, which is the skull, and the normal content, which is the cerebellum. The second one is the removing the mass effect of the tonsillar herniation, and third, normalizing the regional cerebrospinal fluid flow. So if we put this in simple terms, Chiari malformation comes down to buying space. You have a discrepancy between the container and the content, the shoe which is too small, the foot which is normal otherwise, so you have to buy space. And you have two alternatives. You can buy space towards the outside or towards the inside. How do you do it towards the outside? You can crack the skull open and stay there. And that is going to be the equivalent of, imagine for a second that you have Thanksgiving dinner and you start getting stuffy. So you pop a button, you pop the belt, and you unzip, and all of a sudden you're feeling better. That's what removing the bone is going to make you feel better. And you bought some space on the outside. Now, another thing you can do is to open the dura, which is the membrane around, kind of the second skin around the nervous system, and you can add a duroplasty. That buys you, again, more space on the outside. What's the difference between the two? If you look with a reliable parameter, you cannot ask how are your headaches to two different patient population. Patient with skull removal only or skull plus the duroplasty. Because, as you well know, not all the patients are the same about how they perceive the pain. Some patients have been on pain medication for a long period of time, others less. Some people are more stoic, other people are like Italians are like this. So you cannot use that as an accurate measurement. I'm Italian, so I can say that. On the other hand, if you use something objective, something you can measure, at that point you have in better shape. So if you use the syringomyelia deflation as an effect of the efficacy of the surgery, at that point you're going to have some good hard facts. Syringomyelia cavities deflate, and deflate significantly, in about 65 to 70% of the patients who get cranial decompression alone, in which just the bone gets removed. The moment you start doing the cranial decompression plus a duroplasty, you go up at 85%. The moment you do also the tonsillar shrinking, you go up in the mid-90s. So if you use something you can measure, there is definitely a difference between all this. How you buy space on the inside? Again, from here to here, this is tonsil. This is the part of the tonsil which is herniating, but the tonsil actually goes up to here. And again, is free-for-all tissue that you can manhandle at your own pleasure without any consequence, providing that you do not make a mess of all the innocent bystanders around. So, how do you shrink it? Imagine that you have a filet mignon and you put it on the grill. Okay, if you forget it there because you go and answer the phone call from mommy, you're going to come back after 15 minutes, your filet mignon from like this becomes like this. What has changed? The heat has boiled as some water off, so the water content has decreased. So you can shrink the tonsils by porocoagulation, so which is a pair of chopsticks connected to an electric cable. You pinch the tissue, you pass the electricity produces heat, and the heat cooks that part of the tonsil. Now, there is a limitation in this. You cannot cook the entire tonsil. You cook the part of the tonsil you can reach safely. So when you cook just this part here. You do not cook here because there's an end of brainstem. You can't reach there. At least you cannot reach in the very beginning of the surgery for sure. So you're not really cooking your filet mignon on the grill. Imagine that you have the filet mignon and you're just doing 2 square inches of the filet mignon, and that obviously is not going to give you a big amount of shrinkage, but again, it's better than nothing. Another process you can do is to cut the tonsil. Subpial tonsillar resection is something which has been around probably around 30, 40 years. It's just more difficult to do, but you can remove safely 2/3 of the tonsils on the right and on the left, around 2, without any consequence for the cerebellum and the surrounding structure. It's just more difficult to do, but that buys you an enormous amount of space, directly where the problem is. So, surgical building blocks. These are all the things that you can do during the surgery. You can cut the bone, you can cut the first vertebra, you can just cut a little bit the surface of the dura so the dura stretches a little bit. But you do not open it. You can open it and do a duroplasty, which is a dural grafting. You can use synthetic materials. Pericranium is the best. I just spoiled the surprise. You can use or not use a cranioplasty. You can use a tonsillar dissection, which means just moving the tonsil around, shrinking them by doing porocoagulation, or cutting them. There is a spectrum of continuum of steps from here to here. Easiest to do, most difficult to do. And you can go from here to here from here to here, to stop at any point or pushing all the way. This is a typical anatomy you can have in the most standard approach for Chiari. C1 laminectomy, the first vertebra has been opened. This is actually a small size posterior fossa craniectomy, pretty much what Dr. Besser would have done and still does. And this is pretty much the prototype. Now, there are no standard of care for Chiari malformation surgery. The only thing that everybody agrees is that the problem is here, we have to operate there, and then we use the building blocks that we said before. But other than that, there is no rule saying we should just open the skull, we shouldn't open the skull and do the duroplasty, blah, 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 stop here, stop there. This is an example of duroplasty. This is a duroplasty made with pericranium. Not all the duroplasties are the same. Being a guy who has dealt with many reduced surgeries, I can tell you right away what are the duroplasties which do not work. Duroplasty which are a major no-no are alloderm. Alloderm is a material which works very well in many other places, should never be used in the posterior fossa. The worst disasters I've ever seen in post-operative patients that then they had to fix, and again, the patients are never the same afterwards, are from alloderm. Then there are people who are preferring getting synthetic materials, which means I get a piece of something from a jar which is on the shelf in the operating room, or harvest it from the patient. The best takes just more time to harvest it. It takes special skill to harvest it. If you know how to do it well, if you like everything, like tying your shoes, the more you do it, the better you get, is the pericranium. The pericranium, use of the pericranium has the least amount of problems in terms of allergic reaction, cerebrospinal fluid leakages, inflammatory processes, postoperative infection, etc. It's not even a competition. But it is challenging. You have to harvest in a certain way. You have to either extend the incision or make a secondary incision. And in patients with EDS, since guess what, their entire tissues are defective, this cannot be an exception. So you're going to have a tissue which has the same flaws of the rest of the tissues of an EDS patient. This is an example of tonsillar herniation with the dura open. This is the brainstem at the junction with the spinal cord here. And this is the rest of the cerebellum up here. Now, one thing you can see here is this. You see that these stripes of the cerebellum go like this, kind of horizontal? And the spinal cord and the brainstem do not have any more of these stripes, and the stripes of the tonsils go vertical. That's an easy way, in case one of you guys wants to try it, to distinguish where the tonsils are ending and when they're starting, and what you can handle and what you should not handle. If you start messing up with this part of the cerebellum, you're going to have somebody who's going to eat the ice cream like this, because the coordination is going to be off. Fortunately, the cerebellum can take a joke pretty much. You can bang it with a hammer, and the rest of the cerebellum actually has what we call plasticity, can take over for many of the function of that part of the cerebellum which is gone. So if in the aftermath of the surgery somebody is a little bit off with the finger to nose things, in the immediate aftermath of the surgery, you know as a surgeon that everything is going to clear off in a matter of a few weeks. So this is before the shrinking. This is after the shrinking. So the tonsils were down here, and this was the form, and now they are up here. Now you see this thing over here? This is called the Foramen of Magendie. The Foramen of Magendie is an important structure for the circulation of the cerebrospinal fluid, much more important than anything else in that regional area. That's the reason why when people with Chiari malformation cough, they feel that their head is exploding. The Foramen of Magendie is an equalizing valve between the spaces which are inside the brain and the spaces of CSF which are outside of the brain. When you cough, the skull does not change in shape, or size or volume. The brain is still the same 1.5 kilos that you had before. Does not change in shape, size of brain, size of volume or weight. The only thing which changes when you cough is that you have an increasing amount of blood which comes in and a decreasing amount of blood which goes out. So you have an excess X amount of extra blood which stays inside. Now, if you have a box which is fixed size and not expandable, and you have three ingredients, one is the brain, one is the cerebrospinal fluid, and one is the blood, and two stays constant and one goes up, the pressure is going to go up if the volume, the sum of the volume of the three is going to go up. So why the CSF is the problem? Because in normal circumstances, this hole is not covered by the tonsils because the tonsils are tucked in inside the skull. And if that valve is open, when you cough and there is more blood going in, staying trapped inside the skull, guess what the body does? Pushes CSF out. Pushing CSF out towards the spine, the subarachnoid spaces around the spinal cord, keeps the pressure even. So if you put a monitor over here, you're going to see somebody coughs, the pressure goes up to 80 and then comes down in a matter of a few seconds. If you put in somebody with Chiari malformation in which this thing is covered, you're going to see the pressure goes up, then it comes down, but doesn't go down to normal within a few minutes, but stays up around 40, 30s, high 20s for several minutes, practically for the duration of your misery. So imagine a pressure cookware, and there is the valve on top. Imagine that your child puts crazy glue on top of the pot, which is full of water boiling. What's going to happen? A big mess in the kitchen. So this is the equivalent. This equalizing valve is supposed to stay open. The tonsil cobs staying on top are going to cover it. Now you understand the difference of the problems. If I just cut the bone and my tonsils are still there, or they ascend a little bit, but the heel is still open, the patient is going to be better. But they're not going to be as better as somebody who has a massive shrinking in which the tonsils are no longer covering the foramen of Magendie. So the other thing which is important in the tonsillar shrinking is the fact that there are other structures beside the brainstem in the air. And these, you see all these white thingies here? These are the 11 cranial nerve. The 11 cranial nerve is in charge of the innervation of the sternocleidomastoid and the trapezius, so practically allows you to do like this. Now, the issue with this nerve is that it's not just a motor nerve like initially people were thinking, but also has a sensory component, which probably comes from the proprioception of the muscles related by the innervation. Long story short, that's the reason why the headache of the Chiari radiates to the shoulder. There is no other reason, no other way to explain it. So if you have still, the tonsils are kind of, they're not just two triangles coming down over here, but they're actually bear hugging the brainstem in this direction, and they're here and they're pushing against this nerve. So if you want that annoying pain towards the base of the neck to the shoulders to go away, and not just the headache to improve, you have to go after the tail of the tonsil and to shrink it. So generally, when you decompress the skull, you affect just the posterior part of the tonsils, but this part which is stuck in the corner does not get affected positively. So this, for example, is another visual of a shrunk tonsil. The tonsil before was down here. This entire triangular space was packed with that. So the vertebral artery, the pica, which is an artery feeding the brainstem in this area, and all these rootlets of the 11 cranial nerve now are fully decompressed. Cranialplasty. So you make a big hole and then you cover it. The first guys doing the cranioplasty in Chiari patients, Dr. Murad and myself, was 1998, was Long Island College Hospital. Why we started doing that? Because Dr. Murad realized back then, when everybody was just doing a cookie cutter operation, which was posterior fossa decompression, C1 laminectomy, open the dura, do the duroplasty, he discovered back then that by removing more bone, the somatosensory evoked potential were improving more and more. All right? So at that point, you have a big hole in the back of the skull. You cannot have somebody with the mushy part here. Otherwise, when they go to sleep, they're going to have the pillow pressing against the cerebellum. So we had early on the problem of, okay, we removed the piece of the skull which was too tight. So now let's make a piece of the skull, artificial skull, which is larger. So instead of something which is pushing down, let's give it more of a convexity to it. So we came to this, you see it is a little bit more curvy than not this part of the skull. We did it for a number of years. And then, exactly when everybody else was starting doing cranioplasty, we stopped. Because we realized that, again, on the large numbers, not everybody was needing a cranioplasty. Not everybody was needing a large craniectomy. And first of all, very early in the game of just removing the skull, we realized that removing the skull alone was giving very good results short-term, bad results long-term. If you were going at the 5-year mark, the vast majority of these patients who were having the large craniectomies without the cranioplasties were not doing well, and they were actually needing an intradural operation with the tonsillar shrinking duroplasty to get to the next level up. Fast forward many years later, some pediatric neurosurgeons discovered the same thing. If you open more the skull, you're going to find the same SSCP changes. Right now, they're starting having the same problem. They're seeing that there is an unexpected amount of scarring between the dura and the surface of the brain, and they cannot explain, some of them, why is there? We did not open the dura. It comes from the friction of having the muscles rubbing against the dura, against the brain, and you lying against the pillow, which lies against the muscle, against the dura, against the brain. All right, so we have all those building blocks.